So hi everyone, today we're doing an in-service about COPD, and we are located at Mount Sinai Hospital, and we're just nurses who are going to be talking about the complications of COPD and everything that comes along with it. So my name's Alexa.
My name's Hammy.
And my name is Alyssa.
And Ali is going to start us off with introducing COPD, and then we're going to rotate on to me and Hammy's part of the presentation, okay? So we'll start Ali off.
And if anyone feels the need to ask any questions or add anything in, please do. We don't mind. This is just an in-service so we can do a little learning and discussion together.
Right. All right. So start us off.
So COPD stands for chronic obstructive pulmonary disorder. By definition, it's a chronic inflammatory lung disease that causes limitations in lung airflow, and it's a largely preventable disease, meaning all of those modifiable risk factors like smoking, occupational hazards, those are all things that can, if you don't partake in them, can stop you from getting COPD. So it's an umbrella term, so it encompasses two disorders in particular, emphysema and chronic bronchitis. They're a little bit different from each other, so I'm just going to discuss them in particular. So emphysema is caused by destruction of the alveolar walls. So if you think of, I'm going to take an example. So if you think of you're a smoker or you are a painter, and you're inhaling all these fumes and it's not healthy for your lungs. And that can cause your alveoli to break down. So if you think of your alveoli in your body as a bundle of grapes, it has a lot of surface area. So if you were to compare it to a balloon and a bundle of grapes, what does have more surface area? Can anyone tell me?
The bundle of grapes.
Yeah, the bundle of grapes does have more surface area. So what happens in emphysema, so if you break down the walls of the alveoli, it causes 10 grapes per se into one grape. So the surface area is decreased, causing decreased O2 perfusion, and that's what causes those signs and symptoms like trouble breathing and stuff like that, and it causes hypoxemia. And then we have chronic bronchitis, which is caused by inflamed airways and hypersecretion. So it's associated with a cough or sputum production for more than 3 months in 2 successive years. So again, if you think of your lungs, there's a mucous membrane that protects our bronchioles in general. But if you think of our lungs as a circle and the mucus on the inside, the more mucus you're creating, the more you're bronchoconstricting, right? So that inhibits your airflow. And also with chronic bronchitis, you're more susceptible to respiratory infections that way. So those are the two different ones. And we also look at asthma. So we use asthma kind of in correlation with the umbrella term, but it's not what COPD is. It's just the major risk factors. So if you think of having asthma or being asthmatic, you could be asthmatic because of spasms of your bronchioles. So that already causes bronchoconstriction. If you add on smoking causing the emphysema or the chronic bronchitis on top of it, it can cause COPD. So it's one of the major risk factors, and it's worth noting. Yeah. So COPD stages and severity. So stage 1 is mild. Symptoms can be present or latent. Normally in this period of time, your patient won't know they have COPD. They'll write off their symptoms as something else, right? So by definition, does anyone know what a FEV1 is?
Forced expiration volume.
Yeah. So our forced expiration volume should be above 80%. The amount of air that you can expel should be above 80%. With COPD patients, if they're in mild stage, it's about 80. And they could have a chronic cough and sputum, as I said. And then stage 2 is moderate, so they do have chronic symptoms. They may be having some appearance of dyspnea on exertion, for sure, and shortness of breath when hurrying on the level of walking or slightly uphill walking. So that's different to say me walking up 2 flights of stairs and being tired because I'm not in shape. There's a difference between that and shortness of breath. And most people don't know that. So if you're talking to a patient who has the risk factors associated with COPD and maybe at the mild stage, discuss the difference and discuss that if they do happen to be shortness of breath, and in tripod position, say you walk up a flight of stairs and you're trying to catch your breath, then that is a sign that you should come in to the doctor, and we'll figure out a plan of care for you. So at this time, normally they have a FEV1 of 50 to 80% of value. So then we get into stage 3, which is severe. Your dyspnea worsens and they have more exacerbations. So they could be doing less movement and having more shortness of breath, right? And then stage 4 is very severe, so stops for breath after walking 100 yards. 100 yards is not a far amount to walk. If someone can't breathe at that point, then they are in need of care, and they're also at risk for getting heart failure. If you think of heart failure or a lack of oxygen to any vital organs, especially your heart, it can be detrimental for you. So at this point, their FEV1 is just below 70. So something that is to note, and something to tell your patients, if you are dealing with someone who's in stage 1, stage 2 of the COPD, is that it is a progressive disease. So it's better to stop it at stage 1 and stage 2. So stop all those risk factors at that time so it doesn't progress to stage 4. It's important to mention these complications so that in the future, they don't end up at stage 4 and it's not reversible. Okay, so this is just to visualize your normal lung function. Blue is the good, gray is the bad. So obviously, through the progressive disease, the gray overrides the blue, meaning you have more problems breathing, more problems with your lungs in general. Okay, so now we're going to move on to pathophysiology. Alexa's going to actually come up and talk about that.
My name's Alexa, and we're going to start off with the pathophysiology part of the presentation. So first we're going to start off with COPD. We know that it's a chronic inflammatory process. And what does that mean? That the bronchioles, anything part of the lung is inflamed, right? So that can go to your arterioles, it can go to your alveoli and your bronchioles. It's all inflamed. There's excess mucus production, as we see here, so it's hypersecretion. So the patient, they're gonna have a chronic cough because their bronchioles are gonna be very irritated by the decreased ciliary function. So there's gonna be ciliary dysfunction as well, because when they're, for example, smoking, those chemicals are gonna damage all your protective mechanisms that are part of your lungs, right? So they're gonna have a chronic cough. They're going to have excess mucus production, so you're going to see them cough up maybe some kind of brownish looking sputum, so you want to look out for that. There's going to be hyperinflation of the lungs and loss of elastic recoil. So that's important too, because that provides your lungs with the chance to expand and then recoil, right? But with the loss of recoil, they're not going to be able to breathe as well. And gland enlargement, that's just connected to, they have enlarged submucosal glands, so that's going to lead to the hypersecretion, right? So then there's going to be abnormal gas exchange as well with the damaged alveoli, because it's going to be impaired gas exchange resulting in the hypoxemia, and hypercapnia will be present as well. So what is hypercapnia? Can anyone answer for me? What is hypercapnia? Yeah?
It's the increase of CO2 within our body.
Right, right. So that's a major characteristic of their COPD patients. They have a lot of CO2 in their bodies, right? All right. So we have our risk factors. And one of the major risk factors of COPD is smoking. So COPD is a primary, so tobacco exposure is the primary cause of COPD. It occurs for 80 to 90% of the cases. So when you inhale cigarette smoke, you're inhaling around like 4,000 chemicals into your body and into your lungs, and that causes the damage to your ciliary function, to your lungs, to your alveoli, right? So exposure to tobacco smoke is usually measured with the patient in like packs per year. So obviously the more packs that they smoke, the more damage that they cause to their lungs and everything, right? So what is found in cigarette smoke. So it's your like carcinogens, and that's what causes the damage to your lungs. And if we want to go further, more in depth in it, just to get a further understanding of why smoking is so bad, is because in your body, your hemoglobin, your carbon dioxide, there's a more higher affinity for your hemoglobin. So that is going to attach to hemoglobin more readily than your oxygen. So that's why they become shortness of breath and everything else that comes along with COPD, right? So if we want to look into more like kind of the nursing role, because smoking is obviously addiction, right? So when people smoke this much, they're going to be addicted to that smoke, to that nicotine, right? So, I mean, it's going to be hard for them to quit. So you can't tell them like you are going to stop today at this very moment. So you have to encourage them that this is a progression, that you are along with them to help them, you know, delay their progression of their symptoms and everything. So we can use, you know, part of our other team, like respiratory therapists or social workers, just to help them out with their progression with this disease, right? And then you have your alpha-1 antitrypsin deficiency. So can anyone tell me what that is? Yeah?
It's a protein that's found in your lung, and it helps protect the surface of your lungs.
Right. Right. So it's inherited as well. So it raises your risk factors of developing lung and liver disease, right? And then we have your occupational factors. So we know that working as a coal miner, working anything in an industry where there's a lot of chemicals, a lot of fumes, your lungs, they're going to be consuming that, and it's going to lead to damage, and that furthers your risk of developing COPD. So we have your construction workers and all that. And then we have our infection, which is a huge, huge cause of COPD. So this leads to the destruction of your protective mechanisms in your lungs and the ciliary functions in your lungs. And increased age, because when you have increased age, it leads to your loss of elastic recoil. So your muscles and everything become more, what do you call it? What's the word I'm looking for? They become harder and
rigid.
Yeah, that's what I'm looking for. So keep in mind, so what we talked about before, COPD is progressive. So it is very important that our main goal as nurses, is to support the patient and tell them that this is, our goal is to ease their symptoms, and this is a progression. We have to work together just to delay the progression of their disease and everything, right? So there could be periods of exasperation. So sometimes they could be worse, sometimes they could be better, but our goal is just to make it a balance, right? Okay, so we have our complications as well. So pneumonia is a major complication. And so what is pneumonia? It's acute inflammation of the lung caused by certain bacteria. So you can catch it within the hospital. It could be hospital acquired, it can be community acquired, and it's very common within the community. And it's also demonstrated as fluid in the lungs. So that leads to shortness of breath and crackles in the lung when you auscultate. Right, and then we have our acute respiratory failure. We have our core pulmonary, which is enlargement of the right side of the heart due to pulmonary hypertension. So that could lead to your right side heart failure due to the disease in your lungs. And respiratory drive changes. So we know that there's a lot of increased CO2. So we're gonna talk about that further on into the presentation. But basically, it can lead to your oxygen toxicity if you're giving too much oxygen to a patient that is so used to being to living off an increased amount of CO2. So that is our complications. All right, so we're moving on to a bit more of a fun part of our presentation. So we have our signs and symptoms. So I'm gonna ask you guys in the audience that what are common signs and symptoms that you have seen in your patients with COPD? The first things that come to your mind. So we're gonna set a little. So I'm gonna get you guys to think about all this stuff, and then we're gonna go straight into it. Okay, so what are some common signs and symptoms?
Dyspnea.
Shortness of breath.
Yeah?
We've got barrel chest.
Yeah?
Patients can be put in the tripod position.
Yep. They can be presented in tripod position, dyspnea,
Low O2 stat.
low O2, so we're talking about the oxygen saturation, so you're not going to see a normal oxygen saturation as we would see in meat, which would be 98%, right? So we would see them more in kind of like the high 80s, maybe low 80s.
Finger clubbing.
Finger clubbing, yeah. So what would you hear if you're auscultating their lungs?
Crackles.
Crackles, wheezes,
Diminished.
breath sounds, correct. All right, so we're gonna go through them. You guys hit a majority of them, so good job. So you have your shortness of breath with your increased fluid in the lungs, with your increased hypersecretion of your mucus. We have our dry cough. We have our excess mucus production, rapid breathing. So sometimes you can come in contact with a patient who has like maybe a respiration of 30 breaths per minute, right? So you want to kind of focus on their breaths and their oxygen saturation. Tightness in the chest, they can be suffering from wheezing, as we said, decreased breath sounds, finger clubbing, which is kind of a late sign, so if you don't see them with the finger clubbing, it may be more of a delayed progression of that. So tripod position is very common in COPD patients. So we're going to show you a picture of what that looks like, and I'm pretty sure you guys have seen that before. So barrel chest, thin and malnourished, and dyspnea. So this is our tripod position. So you're going to see your patients who are leaned over trying to get more of that oxygen in. So this is kind of like the stationary position that you're going to see their patient in. Your finger clubbing, and then this is your barrel chest. So it's going to be more, your intercostal muscles are going to be more like a barrel rather than normal, as seen over here. Okay. So just look into your clinical assessment. So during your clinical assessment, you're obviously going to be asking about their smoking habits, how many packs they smoke per day, per year, and kind of getting like an overall look at how their lifestyle is at home, what their family is like, what medications they used to take in the past and what they're taking now, so we can kind of redirect our attention to something else and prescribe something that works, create a regime that works for them. Doctor recommendations, we want to see what the doctors have said in the past hospitals during the referrals, and their employment. Obviously, coal mining and all those construction industries are very high risk for people who have COPD, so you want to ask them how long they've been working for, are they still working, they retired, all that stuff. So obviously family information, and then how the patient feels at this exact moment, because they can be anxious, they can be depressed, and you want to make sure that they know that you're there to help them and to provide support. So now we're moving on to diagnostic studies, and Hami is going to cover this section. Okay, thank you.
So hi everyone, my name is Hami, just like Alexa mentioned, and I'm going to be starting off with the diagnostic studies or forms of diagnosis for COPD today. So basically we start off with spirometry. The spirometer is basically the first line of measure for COPD and the first line diagnosis for many COPD patients. It's used to directly confirm the presence of disease once a physician or a specialist thinks that a person for sure has COPD to confirm it. Next we goes on to chest x-rays and chest CTs. This is used for patients that are usually suspected of COPD, which is a little bit different from someone that already thinks to or already seems to have the presence of the disease. It's used a lot of the time to rule out a lot of other comorbidities or other diseases that the patient could have due to the signs and symptoms that are present. So basically with the chest CT and chest x-ray, usually what many COPD patients presents with in their x-rays, just for our knowledge as nurses, in case many of you are wondering, is that you'll see the hyperinflation of the lungs. There's little flattening domes of the diaphragm, and there's also tapering of the pulmonary vessels within the x-ray or the scan. Another test which is not usually used often as diagnostic study is our alpha-1 antitrypsin deficiency testing. This basically is only for certain patients that might show past medical histories with no onset or no indication of COPD at the present moment. It's with patients as well that usually have the unlikely chance of having COPD. Now, can anyone, with alpha-1 antitrypsin, as mentioned before by Alexa, it's basically a protein that's found in your lungs that helps protect it. But if there's a deficiency of it, then there's more chances of lung or liver disease. And then there's also ABG testing. Does anyone know what ABG stands for?
Arterial blood gases.
Yes, great, thank you. So it's basically used for people that are already diagnosed with COPD, but it's for the people concerned of more severe COPD that goes into our usually 3rd and 4th stage of COPD. So now we know through Ali that the 4th stage of COPD usually leads to heart failure, which is another reason why ABG testing is used, as right-sided heart failure is an indication of the severity of it, and usually patients show more comorbidities due to this as well. So moving on, we also have treatments and interventions. So once the diagnosis of a COPD patient occurs, as roles of nurses and roles of people within the medical field, we try to help our patients and also find small little methods of them to cope with COPD. So goals that we can establish for a lot of the patients admitted for COPD are improved ventilation and symptoms relief. As well, we also look for giving comfort, delaying the progression of the disease as it is a progressive disease. Smoking cessation, and this basically works as to diminish or to lessen the amount of smoking a person with COPD has. So it goes through 4 main stages of ask, advise, assist, and arrange. We'll go more into we went more into smoking cessation before, but we do want smoking cessation to happen in not in one go, but in a smaller time frame, just so that people lessen the amount that they smoke, because for many of us, we find that by just telling a patient to stop smoking, that they actually don't follow this regimen, which makes it harder for them to cope with their disease. So now we're going to go into 2 different ways to help a person with COPD breathe or expel mucus or secretions. So I'm actually going to grab someone from the audience to help me. So Alexa is actually going to help me. So huff coughing. Huff coughing basically helps with the secretion and mucus secretion. And what we have is we're going to have Alexa sit up straight. And it's going to involve pursed lip breathing. So she's going to actually first inhale through her nose. And she's going to hold for 3 seconds there. And then she's going to release that in 4 increments while she moves forward. And then she's going to basically it out. Yeah? And that's going to be repeated 4 times. So do you want to just do that one more time for everyone, Alexa? Great. So that basically helps with the clearing of secretions for COPD patients. And with that, many of you could see that Alexa was doing what we call pursed lip breathing. And that's actually the main thing, the first thing that patients should be taught. It's basically inhaling through the nose and exhaling through pursed lips, almost like how our lips look around a straw. It helps to improve respiratory function. So this usually most patients who are even before they're diagnosed with COPD have trouble breathing, or that dyspnea or the shortness of breath. And a lot of them go naturally into a pursed lip type of breathing just to expel more air or to increase their oxygen flow. So, moving on, another form of treatment that we go to for some patients is oxygen therapy. So there's different types of devices based on the amount of oxygen that we're giving to our patients. So with low flow devices, we have 2 prominent ones, at least in our hospital here at Mount Sinai, that I'm sure many of you have seen. We have our nasal cannulas, and usually that gives a rate of less than 4 liters of oxygen per minute. And this is a very good knowledge for us as nurses, as many of us do realize that we can usually only give 2 to 4 liters for our patients before getting help from a respiratory therapist. But if you do need help prior to that, please do contact them. We also have our face mask, and the face mask gives a little bit more than 5 liters of oxygen per minute, and these are very simple face masks that we use. And we also have our partial breathing mask, or our non-rebreathing mask that we use within it. And then going on, we have more high flow devices. So do take in that for face masks, it can also be known as a high flow device depending on how much oxygen is being set through it. But usually we use Venturi masks. So Venturi masks are basically a mask that allows more inflow of precise oxygen, or more concentration of oxygen to inflow, and they're very good for the use of COPD patients. I'll actually revert back to a picture that was on one of Alexa's slides here. So as you guys can see in this picture, there's an orange little tab, and that's actually what makes the Venturi mask itself. It's so just depending on the sizes that the masks are presented with, it allows more concentration or less concentration depending on what attachment you decide to use. So that's different for every single hospital. Okay, moving on. So we also have pharmacological therapy, or medications that we give to patients with COPD. So we start off with bronchodilators. So they're usually indicated for a lot of severe cases, so our stage 3 to 4 patients. They help relax the smooth muscles of our bronchioles that then cause them to dilate, which helps the narrowing that happens simultaneously by COPD. So there's 2 types of bronchodilators: a beta-2 agonist, which is our Ventolin, which a lot of physicians do prescribe to a lot of patients that have COPD, or our anticholinergics, which is Atrovent. And do realize that these are the trade names, but we do have the generic names listed above as well. Then we move on to our corticosteroids. They're indicated for patients that have inflammation due to COPD. So corticosteroids are used more in the cases to deal with the effects of COPD. They're also used for patients with asthma, which is also another risk factor that we talked about that's associated with COPD. An example of this is prednisone, which is at times highly used in our hospital. I'm sure many of you have seen it before. So, and also realize with a lot of medication therapies, if there's any time that any of the nursing students you have, or any of the nurses on floor, if you do think that a patient might need a change in prescription, or you are wondering or questioning the prescription that's given them, please contact the pharmacist or the physician that ordered the prescription to talk to them. Please use all parts of the multidisciplinary team that we will go over at the end of this presentation. So next we go into nursing implementations. So this is stuff that, because as nurses and as part of the medical field with our patients, we're trying to help them improve their daily lifestyle, even with handling the disease itself. So we start off with gradual smoking cessation. So I talked about this a little bit before, and this is basically gradually decreasing the amount of packs or amount of tobacco inhalation that they're using. Just because a lot of the patients are new to COPD or aren't able to cope with it, and for some, smoking is actually a way of relaxing, and by taking it away, it causes a lot of anxieties. Therefore, instead of fully doing cold turkey for a lot of our patients, we do ask that they just gradually decrease it. And there's also implementations of other forms of getting nicotine besides cigarette smoking that slows down the amount of nicotine we get, and also slowly stops the smoking itself. Does anyone know any other forms that we can use to help with someone trying to get off smoking?
Patches.
Yeah.
Nicotine patches.
Yeah. So that's good. That's one of them. We also have the gums that the chewing gums that can be used, nicotine gums that can be used, and those are great as well. But all of those do have to be talked to with the physician or the respiratory therapist, or even the dietitian at that point, and the pharmacist. As well with that, we also want to teach our patients not to put themselves in high-risk environments. And when I say high-risk environments, I mean environments that have a large amount of pollutants or chemicals or anything that's inhaled in through our COPD patients' lungs that can make them have episodes or exacerbations of the disease itself. So for example, a person that's a construction worker, so we do recommend that they do not put themselves in places with a lot of dust, a lot of pollutants, as it does make it worse for them. As well, patient teaching, guys, this is a very big deal here in our hospitals, as it's not just teaching them how to cope with the disease, but how to efficiently cope with it, as a lot of patients are still getting used to it and they're not understanding. So this is a very big thing with medications, as well as we do tend to try to teach our all the staff here at Mount Sinai how to teach our patients how to use inhalers or use them properly. So we should go over that as well. And then fourth thing, as you can see with all the exclamation parts, hygiene. We do know that COPD patients are more prone to respiratory infections, so hygiene is a very big thing that we would like you guys to go over with your patients as well, and for you to keep yourself as well. And last but not least, our multidisciplinary team. So this is just everyone in the staff that works together. So if you guys ever need help in regards to anything, so a respiratory therapist is really great in the use of our COPD patients in cases where you guys want them to teach them how to breathe or how different ways of breathing or coping, as well as even just to use their medication or O2 therapy. And then we also have our dietitians. So dietitians are ordered usually because some patients actually with COPD can have malnutrition due to the fact that they're more focused on breathing and they're more focused on getting all the airflow that they need, that at times that they don't worry about their diet. So malnutrition is a side effect of COPD that can happen, and you'll see that in patients that drop in weight. So if you do see it, please contact a dietitian or set your patient up with a dietitian just so that they can get the help they need. Pharmacists are great if you're ever, like I said, questioning an order or questioning medication that's been sent up for your patient, or your patient is saying that they've been taking medication and it doesn't help. Social workers are great, as this is a progressive disease and we are trying to help our patients cope as well. It's not just for them, but it's also for their families itself to cope with it, as no loved one wants to see their patient, no loved one wants to see their family member having trouble breathing. So nurses are also, nurses like us alone, we're there 24/7, we're there for the help, we're there for the support, and we're there for the knowledge. So help your patient with what you can, and if you can't do it alone, please use parts of your multidisciplinary team. And physicians, again, are great for diagnosis, and if you need to reach them because your patient wants to ask a question or the family member has concerns, don't hesitate to call them, even though they might be scary sometimes. Do call them, because they are part of the team that you can use to help you. So that actually goes to the end of our presentation for today. I hope you guys all had fun at our in-service, and we'll see you at the next one. Oh, hey Alexa.
Hey.
Come on in here. We actually have a new admission today.
Yeah.
So he's actually coming from Mount Sinai. He just moved, so he's coming from Northridge General.
What's his name?
So John Shepard. He's 80 years old. He was originally from like downtown, but he just moved up to Northridge.
So he's 80 years old. His name's John Shepard, and he just moved from Mount Sinai to North York, right?
Yeah, Northridge region. He lives with his wife.
Yeah.
Ali. According to his file, he used to be a smoker. He's gradually stopped because he's actually been diagnosed with COPD. He was diagnosed during his visit to Mount Sinai a couple years back. Apparently it was due to his smoking, number one, but it was also due to his previous work in construction.
So it says he smoked 1 pack per day?
Yes, 1 pack. Okay. Sorry, I didn't mention that. And apparently he also grew up with secondhand smoking due to his parents when he was a child, so it led to him having asthma. He actually visited Mount Sinai about 5 years ago. That's when his actual diagnosis, when doctors thought that he was COPD diagnosed. He was diagnosed through, I think they did the spirometer, and it was he had second stage. They ordered a chest X-ray and CT and lab diagnostics. So his spirometer test actually came back to his force expiration as -2.35.
Okay.
His FVC was -3.9, and then his difference was 60%.
Wow. All right.
Yeah. So the X-ray actually showed. I'm just gonna let you know, just in case if you do want to see his past history. He had increased basilar markings.
Basilar markings.
In
Okay.
his,
With overdistension.
Yes, overdistension.
Okay.
His diaphragm was also apparently flattened.
Okay, and it also says he was prescribed with bronchodilators.
Yes. He's on it twice a day. He was apparently taught at Mount Sinai by the respiratory therapist how to take his medication and everything. There's been certain variations in the last couple years, but other than that, it stayed the same. It was still Ventolin, even till now. And other than that, he doesn't seem to take any other medications unless the ones that was the Mount Sinai.
Okay.
He's actually gonna be in I think an hour or so. He called
For what, worsening symptoms?
Yeah,
symptoms.
It seems like he's having an episode of it. He's not sure why, and he's quite worried, so he's gonna come in as quickly as he can. So just prep, and I'll let you know. Just read over his file, and I'll let you know when he comes in.
Okay, great. Thanks.
Thank you.
Thank you. Hi there.
Hi.
Mr. John Shepard. Hello. Okay, so my name is Alexa. I'm your admitting nurse for today. So I see that you have been admitted to North York General for your progressively worsening symptoms of COPD. Is that correct?
Yeah.
Right. Okay, and just let me review. You're 80 years old, and you've been referred from Mount Sinai, right? Okay, so so how are your symptoms making you feel now that they've progressed? Like, what's your life like at home?
They've taken over.
They've
to
taken
be honest
over?
with you. I can't really do anything without having to catch my breath.
Like, what's the most that you can do on a daily basis?
Nothing.
Nothing?
Not nothing.
Okay.
But just the most, I thought it was because of my age, but the most intimate, like, just little things make me short of breath. I can't breathe.
You can't breathe? Okay. What's your medication? What medication do you take?
It's this here. It's
okay.
Ventolin.
Ventolin? You take Ventolin? Okay. So how often do you take it? Like, what's your...
Just when I feel like
Just when
short
you
of
feel
breath.
like it?
Yeah.
Okay. So it says, according to the doctor's orders, that you're supposed to be taking this 2 times a day.
Oh, really?
Yes.
So not
yeah,
just when.
it may have been a miscommunication last time, but we can teach you today with a respiratory therapist how to take them, just because it might have led to the worsening of your symptoms.
Okay.
So that will make it a bit easier for you to breathe and get through your daily activities. So do you still smoke?
Yeah.
Yeah?
My wife smokes. A lot of people around me. Socially, it's
Socially
nothing
smoking.
like I was, but
Nothing like you were before? You're an
Yeah.
avid smoker before?
I do smoke. Yeah, I used to have like that.
Yeah, I see you had asthma in the past too. Right.
Yeah.
Okay. Yeah, so for our goal is just to, you know, that smoking is a big cause of your COPD.
I know.
But the good thing is that we can like delay the progression of your symptoms, and we can help you live with it, right?
Yeah.
Okay. So I'm just gonna do a little assessment on you today, and we're just gonna see where we're at. So I'm just gonna test your oxygen.
Okay.
Give your oxygen saturation. Get your finger over here. I'm just gonna do your pulse as well. Okay. Okay. So a minute has passed by. Okay. I'm gonna write down here. Yeah, so I see your oxygen is a bit low. It's around 87. So we're just gonna start you off on like 2 liters of oxygen, just to make it easier for you to breathe. And then, okay. And your blood pressure was already taken before, correct? Okay. I'm just gonna test your breath, your lung sounds, okay?
Okay.
So every time you feel my stethoscope, you're just gonna give me a deep breath, breath in and a deep breath out. Okay? 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 Okay, I'm gonna just put this down a little bit. Okay, I'm just gonna go on your sides. And I'm gonna go on your other side. I'm just gonna auscultate the back just for a minute, just to see how the back is. Deep breath in. Give me a little cough. Okay, great. So what do you notice when you cough? You're coughing up sputum, right? Like a little bit of mucus, and what color is that?
Yellow.
Yellowish to brownish?
Brownish, yeah.
Yellow to brownish, right. Okay. I think that's all we need for your assessment. We're gonna get you started on 2 liters of oxygen.
Okay.
Okay?
Yeah.
It's all good with you? All
Thank
right.
you.
We'll be with you just in a second, okay?
Okay, thank you.
No problem. Had an assessment with John Shepard.
Okay.
And so his results, his oxygen was pretty low, it was around 87.
Okay.
So we're gonna get him started on 2 liters to see how that improves his breathing. He did present with tripod position, so we know that that's a big factor of it.
That's good,
And
okay.
he did look pretty thin, so
Okay.
it looks like he lost a lot of weight, like 30 pounds over the past 5 months.
Okay,
As it
so
looks
he
like.
started with 200, now he's at
He started with
170?
200
Okay,
and
I
he
see.
went down to 170.
Okay, so
His oxygen, yeah, so I told you his oxygen. His respiratory rate was like 30
okay.
in the minute.
Yeah.
So it's
Very
pretty
good.
high.
Mm-hmm.
What else is there?
How's his medication doing?
Okay, so what he told me that he only takes his medication when he feels like he needs to, but I assured him that, you know, he has to stick to his regime, his medication regime, and I told him that we'd get a respiratory therapist later on during the day to just teach him
Okay.
how to take his medications. And his heart rate was 110, so it's a bit high.
Okay. And with that also, with respiratory therapist, good, yeah, we should use her, but also call pharmacy and see what they say about the prescription, because it's, based on his charts, it seems like it's been at that for the last 5
Right,
years.
so we might have to change the prescription.
Yeah. So, you already sent a message out to the physician, yes,
Right.
about it?
Yeah, he takes Ventolin currently,
Okay.
so we might have to just increase the dose. Or
Okay.
increase, because he's on a Ventolin inhaler.
Yeah. See what his physician and what the pharmacy say, and we'll go from there.
I did also notice he was using his accessory muscles to help him breathe,
Okay.
and I noticed a bit of cyanosis on his fingers.
I
So,
see, I see. Okay.
yeah.
Well, with that, then we'll let the respiratory therapist talk to him and assess him as well. We can mention to that during rounds, which we have in a little bit. As well with his weight, I'm kind of worried about that. So the dietitian's going to be there, and maybe we can have a discussion with her during rounds about that. Other than that, do you see anything that might affect it? Anyone else that you think that he needs to talk to?
Maybe we can just, you know, recommend him to like a social worker that can come in just to talk to him, because he seems pretty like kind of sad about his disease or his
Anxious?
diagnosis, a bit anxious, yeah. So we can just do that, but we should get his breathing on board and
Yeah.
make sure that he's easier and he's taking his medications correctly.
Okay, I like that method here. Okay, so we'll just assess and talk about him with the rest of the team, and we'll see what they say.
Yeah, and later on, maybe during this week, I'm gonna get you to talk to his wife
Okay.
just to make sure she knows how to look out for like if he's taking his medications correctly at
Yeah.
home and everything, right?
She's a smoker too, I'm guessing.
Right.
Yeah.
Our whole family.
Okay. Yeah. I'll
so.
have a conversation with the family as well.
Okay.
Alright, that sounds good.
Great,
Thanks,
thank you.
Alexa.
Okay, hi guys.
Hi.
So today we have our dietitian here, Ali, and then we have a respiratory therapist, Hemi. So we're just going to be discussing John's case
Okay.
today. So
Yeah.
today,
Yes,
yeah. So you guys have his chart. So you do know that his name is John Shepard, 80 years old, and he's been admitted today for COPD.
Okay.
Okay.
So
Right?
what are his indications? Like, why does he got it? Why is
Biggest indication for John is, of course, smoking. He's been an avid smoker for the past 30 years. He told me upon assessment that he smokes like socially here and there, but obviously that's still not good for our COPD.
So now?
Yeah,
So
now.
he used to smoke a lot.
He used to smoke a lot before, but now he's kind of
So he's cut it down.
Cut it down.
Okay. So
Based
how-
on his like past experience with the hospital, I think they told him to cut down on his smoking, but he's still.
So they went through the
Okay.
cessation program.
Yeah.
Okay.
So then if he's still smoking, is his family good with him and his regime, or
Not quite. According to him and his family history, his wife has been a smoker in the past too, and even before he had asthma as a child. So I think he's been exposed to a lot of toxins with his family because everyone's kind of been smoking around him. So he's developed that habit too.
So does she smoke in the house? Do you know the wife?
Yeah,
Yeah.
yeah.
so they both did?
Mhm.
Yeah.
Okay. And I'm assuming construction. He said a lot of coworkers.
So yeah, I told him that based upon his smoking habits, or like he like decreased it, I told him that like we would help him,
Yeah.
you know, progressively lead to
Stop. Yeah.
stop,
Yeah.
hopefully stop the
Hopefully.
smoking,
Yeah.
right? Just gradually. I told him that like, you know, we have support systems that would help him gradually stop his smoking habits.
Okay.
Yeah, because it seems to be interfering with his quality of life, and
Yeah.
we don't
Yeah.
want that to totally interfere with his life, right?
Yeah.
So is he having if he's having difficulties with his smoking cessation, how is he with his medication? Because that's quite
Right.
worrisome too.
So he's only been taking his medication whenever he feels like he has to,
Yeah.
and we know that based upon like the order, the doctor said twice a day.
Yeah.
With his bronchodilators. So
The
yeah.
Ventolin. Yeah, he's on the Ventolin.
So that's why we have you here today, because we are just gonna try to figure out like, you know, if does he have to increase his dosages, or like how much oxygen does he have to be on,
Because
right?
he's not been on oxygen, not on here.
Yeah. So
According-
he's been off since he's been to the
Yeah,
hospital last.
he hasn't been on oxygen at home at all. So
No, I don't.
So
I don't
just
think
the
so. I think
Ventolin.
it's just been his medication, but I think based on an assessment, he has 87% of his oxygen saturation. So, what do you think would be like the best intervention to help him with that? Like,
I think
how
right
many
now,
liters?
since he's having trouble breathing, let's react to that first, and let's take
Mhm,
care of that
yeah.
first. So let's start him on 2 to 4 liters. You can decide that based on how he feels and
how he responds to
Yeah.
it. Okay.
So just monitor him while he's on it. Actually, let's start off with 2, and if he feels a little better off 2, let's stop there, because I don't want the chance of him having
intention.
Or
respiratory
oxygen.
drive, because
Yeah.
just in case, because
There's
if
a
he's
high
saying
risk of oxygen.
his oxygen is low, yes, but
Right.
if it's okay with him, like he's still breathing and he still can talk without having issues,
okay.
let's just try 2. If it does not help at all and he's still having trouble
Yeah.
breathing, then we'll just
Then we'll
lift it
increase
up
it, yeah.
by
Okay.
there, okay?
Okay.
Cool.
Okay. And for me, you want me to speak to him as well. I'm assuming it has to do with his weight loss.
Yeah. So he, as you know, he's lost about 30 pounds
In the
within
last
like
few
the
months.
last 5 to 6-ish months since he's been
Yes,
weighed
weight.
before. So that's a lot of weight.
What did he say about his diet? Did he say anything about his diet?
He said that he just mainly focuses on his breathing, and he doesn't really feel the appetite to eat, or he doesn't
Yeah.
feel the need to eat because he's so, you know, occupied with his breathing. So
Okay.
what would you as a dietitian recommend to him?
I'm gonna go in and speak to him. We're gonna talk about a better diet, because obviously he's having trouble with his breathing. Maybe split his meals to 5 or 6 meals per day.
Yeah.
He's losing a lot of weight in a short period of time, so maybe high protein, high calories, because he has a decreased nutritional status, right?
Right.
Also, it's important with the fluids for him. He needs to
Yeah.
do 1 to 3, because does he have dry cough? Does he have trouble passing?
Yeah,
his
I
food
mean, trouble, and when he does, he has like a kind of a brownish sputum.
tinge? Okay.
Yeah.
Because it'll make it easier for him to cough up sputum if we
Like,
have him on
it'll
a
like
lot of fluid.
liquefy
Yeah.
the secretions.
Yeah.
I think we should go in together, because I feel like
Yeah.
I need to
think so
address the
too.
problems that are causing the problems with his
Yeah.
diet.
Mhm.
And I think you should
That's what it
also, with you, should go teach him
Oh yeah.
his breathing and kind of how to
Yeah,
help
we-
him.
He was. You said that he had pursed lip breathing and he was in tripod to begin with,
Right.
So
Yeah.
it's good that he's naturally going into that himself. I'm
Yeah,
sure
because it
that-
helps him breathe,
yeah,
right?
and I'm sure Mount Sinai showed him, but I'll go over with him more. And if he has been having trouble with his medication, I'm guessing that he hasn't been taking it right either.
Yeah, I told him that when I was speaking to him that
Yeah.
part of it is because he didn't stick to his medication. So that is a priority to make sure that we get that patient teaching in and we educate him on, you know, this is supposed to help you and you're supposed to stick to it, right? And we can also help him, like, you know, do puff coughing, like
Yeah.
we've talked before, and to help him get those secretions out.
Okay.
Yeah, yeah.
Um,
When I see here on your notes, he's got a little bit of cyanosis on his fingers too.
Yeah.
Yeah, so he had a bit on his, like, kind of, I think it was like his right fingers, not too much,
Okay.
but we want to place it on the finger that doesn't have cyanosis or like decreased circulation, because that can give like a false reading for the O2 sat.
Yeah.
So if that does progress, we can put it on his earlobe where like there's more
Yeah.
circulation, just to get more of a correct reading.
So I'm guessing it was you took it on his left hand then for his current O2 stat, so you didn't have to on his earlobe. It was okay.
I didn't have to,
Yeah.
but
Okay.
it's just you want to look out for that,
Yeah,
right?
that's good. Let's see what else.
So I think as long as we get a plan together
Yeah.
Yeah.
where we can all speak to him, we
And
definitely
speak to
need
his
to.
wife
We
as
definitely
well,
need to
right?
speak to his
Yes.
family, just because that's going to be the only support system that he has to stick to a regime. And it's been a long time. He was smoking for 30 years. Smoking's been surrounding him, so
Right.
that we need to stop. The medication, once he knows, he wants to get better. So
He
I think
he
he'll
seemed
follow.
very compliant with me. He said that, oh, okay, like, you know,
Okay.
I'll
Yeah.
stick to it if you guys teach me, right? So we
Yeah.
gotta get that teaching in, and maybe, you know, get someone to talk to him. Maybe he has a lot of stuff on his mind that he doesn't want to tell his wife.
maybe a social worker
Yeah.
too.
Maybe he doesn't want to tell his wife, you know, that he's anxious about this, right? So
Mhm.
maybe we should just get him to talk to someone, because, you know, part of it is a lot of like talking or speaking what he feels, right?
And
Yeah.
yeah, I think
Yeah.
the social worker should talk to both the wife and the
Yeah.
husband.
So yeah.
Yeah.
I think that's a good plan.
Okay, so
Okay.
we'll go with that first and
So get him started on 2 liters
Yep.
of oxygen.
see how it goes. Monitors him
Monitor.
every 5 to 10 minutes for
Mhm.
the first like 30 minutes.
We wanna
Nice.
you wanna go through deep breathing with him, just because his
Yeah.
respiratory rate was
We
so
can
high.
even go, yeah.
Yeah, we have to go afterwards because we should address his meals now while he's in the hospital. Because
Yeah,
rather
for
him
sure.
have his weight up
I'd rather him.
now, right?
Yeah, you also we'll get some blood taken too, see if he's malnourished in any way
Yeah.
Mhm.
in that form too.
Yeah.
If he's lacking in something. We'll see. We
How
have
it
to.
goes.
Okay.
Okay.
Great.
Sounds
Thanks,
good.
guys.
Okay.
We'll come to gather around later.
Yeah.
Okay.
Thanks.
Thank you.